classify mental illness? Don't diagnoses just put people in boxes? How can that possibly benefit the individual or society?
In this lecture, we'll discuss some of the benefits and the drawbacks of classification, and take a closer look at the big book of classification. The American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, also known as DSM-5. Just like other branches of nosology, categorising mental disorders allows mental health professionals from around the world to communicate about the same suite of symptoms using a common language.
Using DSM-5, clinicians and their clients can also be confident that their diagnosis will be the same no matter where they are in the world. A diagnosis given in Zimbabwe or New Zealand would be the same as a diagnosis given in China or Poland. And unlike previous versions, the 5th edition recognises cultural differences. In fact, an entire section has been dedicated to helping clinicians understand how being raised in different cultures affects the way we experience or express psychological dysfunction. By using a classification system that is based on scientific research, clients are also more likely to receive an accepted evidence-based treatment. Evidence-based treatment comes about from researchers who run carefully controlled experiments to find out which treatment works the best for which disorder. Classification ensures that terms like phobia have the same meaning worldwide, and that means that researchers from right across the globe can contribute to our communal understanding of that disorder. Statistics about spider phobia in Malaysia can be compared, contrasted or pooled with statistics from Greece because we know that we are all talking about the same thing. Classification and diagnosis also have important legal and administrative ramifications.
For example, a standardised classification system is needed to diagnose post-traumatic stress disorder so that emergency service personnel can receive workers' compensation when they are entitled to it.
There is, however, a risk that classification can create stigma, either from others labelling the person diagnosed or through self-stigma, where the individual judges themselves harshly as a result of their preconceived beliefs. With some disorders, there is also the risk of the person unconsciously playing the role after they are diagnosed,
or can adopt the diagnosis into their sense of self and hold on to it, preventing their own recovery. Diagnoses may also trivialise a person's experience. Being told that most people will experience depression or anxiety at some point in their life can be of little comfort when someone is in the midst of a major depressive episode. But for others, knowing that they're not alone can help them feel less isolated.
It's also important to recognise that for some people, a diagnosis can be liberating. It can validate their experience and alleviate thoughts like, what is happening to me? Why do I feel like this? Why can't I just be happy?
Whilst most people agree that we should have some sort of classification system for mental disorders, there is some disagreement over how this should be done. Do people really fit into neat little diagnostic boxes, or should mental health be viewed on a spectrum? DSM-5 follows the traditions of previous versions, conceptualising disorders as polythetic, where a disorder has a number of symptoms and a person with that disorder need not show every single one of them.
It's also seen as categorical, where the disorder and its symptoms are either present or absent. This classification recognises that suites of symptoms tend to cluster together, helping mental health professionals to specify and differentiate between different disorders. But sometimes these symptoms cluster so well that the person may be diagnosed with 2 or more comorbid disorders.
Because some comorbid disorders tend to cluster together and many symptoms are shared by a number of different disorders, some researchers argue that they may not really be distinct disorders after all, and a dimensional approach to mental illness would probably be more appropriate.
DSM-5 has taken this on board and adopts a more dimensional approach than previous editions. For example, Asperger's and autism now come under the umbrella of autism spectrum disorder. No doubt the categorical versus dimensional debate will be reviewed further for future editions.
So how do we know if a person has a mental illness? How do we know that they're not just sad, but experiencing a major depressive episode. Somehow we need to measure their sadness.
How do we do that?
When scientists measure variables in a clinical or research setting, they first need to decide on an operational definition. In the process of operationalizing, a scientist decides how the variable is going to be defined and measured.
The operational definition of a major depressive episode in DSM-5 states that at least 5 of the following symptoms must have been present during the same 2-week period and represent a change from previous functioning. These symptoms include depressed mood, anhedonia, or a markedly diminished interest or pleasure in all or almost all activities, significant change in appetite or weight without attempting to lose or gain weight, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive inappropriate guilt, diminished ability to think, concentrate or make decisions, recurrent thoughts of death, suicidal ideation, a specific plan for committing suicide or a suicide attempt. At least one of the 5 symptoms must be depressed mood or anhedonia, and all of the displayed symptoms must be present on most days and endure for most of the day.
As we've discussed in the previous lecture, these symptoms must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And the symptoms must not be due to the direct physiological effects of a substance, like medication or substance abuse, or a general medical condition such as hypothyroidism.
The specific diagnostic criteria listed in DSM-5 are much more detailed than previous versions, sometimes including physiological findings from research studies such as electrolyte imbalances in people with eating disorders or enlarged brain ventricles in people with schizophrenia.
DSM-5 also includes other information gained from research such as typical age of onset, prognosis, prevalence, and differential diagnoses to help clinicians distinguish between different disorders that have similar symptoms. By operationalizing disorders in this way, mental health professionals and the public can be confident that we are all speaking about the same suite of symptoms and the same disorder. And if the client receives treatment for depression, they will receive treatment for depression, not grief and not sadness.
Now, the American Psychiatric Association acknowledges that DSM and its definitions are not perfect. This manual is intended to be a never-ending work in progress, being updated periodically as more research is conducted and as our understanding of mental illness changes. It's hoped that by using a common language when discussing, researching and treating mental illness, that we can work together as a global community, finding treatments to better manage, alleviate or even cure mental disorders.
Thanks for watching. In this video, we covered the benefits and drawbacks of classifying mental disorders, whether disorders are better understood as categorical or dimensional, and how mental illnesses are diagnosed using DSM-5. In the next video, we'll take a look at how we got to this point with a quick history of psychopathology, the good, the bad, and the ugly.